Good day. It's Friday. It's time for a Friday Q&A. We've got some questions that people wanted to know the answers to, and hopefully be able to answer some of those questions that I wasn't able to answer on the last Q&A. So like always, I'm going to put this up on the Facebook page for a little while afterwards. So in case you're unable to watch it live streaming, you can watch it for whenever you want, sometime the next week or so. In case you don't know who I am, I'm Corey Babb. I am a board-certified OBGYN. I am a sexual medicine specialist and the director of the Oklahoma State University Center for Women's Sexual Health, which is the first of its kind in Oklahoma. So today, like I said, we're going to take some questions that people have asked over the last week, and like I said, try and kind of finish up with some of the questions that were not answered last time. Let me pull this up here. We had a question about C-section recovery and kind of when women should start to feel better as far as abdominal pain and things like that. So obviously, you think about C-sections, and while they are some of the most commonly performed surgeries in the United States, they're still major surgeries. And typically, C-sections are made one of two ways, either a horizontal incision kind of on the bikini line called a Phalansteal skin incision, or a vertical skin incision that goes from below the belly button kind of down to the pubic bone. The Phalansteal skin incision is typically associated with a quicker recovery time and better cosmetic effect afterwards, as well as some improved pain control after surgery, whereas the vertical incision is more associated with better visibility during the surgery, and some people say a quicker access to the abdominal cavity. So the question basically was, I've had a C-section, I'm still sore, and it's been quite some time. When can I start to feel better? So specifically, they said in the middle of the stomach, a few inches above the incision, have lots of discomfort when my belly is pressed on, whether it's a child running into my stomach or it feels like a huge bruise, and when I bend over as well, it's there. So, in looking at that, remember that the area kind of around that C-section incision, especially if it was that kind of horizontal or that Phalansteal skin incision, you're going to have a large number of nerve endings that were cut with the surgery itself. And the skin, the nerve endings tend to heal pretty quickly, but when they do, they typically kind of have a burning or stinging type sensation, and that's the normal pain response that people get with that. Now, as you go a little bit deeper into the abdomen, we start to get more pain receptors that express themselves in a dull or achy type, crampy fashion. Especially when you get below the abdominal fascia, which is the main support structure of the abdomen. That's really kind of what holds everything in, aside from the skin and things like that. So if you're looking kind of at your incision, you see this kind of area around it that has a lot of discomfort. Well, the first thing to ask is, number one, did the incision, when it was closed, did all of the underlying layers underneath it get closed as well? That includes things like the peritoneum, the muscle layer, that fascia layer itself, and then some of the subcutaneous tissue layers that were underneath the skin too. If one of those didn't get closed, or if it was closed just kind of not really effectively, you can sometimes see an increase in postoperative pain even after months have gone by, especially with that muscle layer. Remember, your abdominal muscles typically are kind of up like this, and when you bend, they do this, and they kind of help pull you down. That's kind of their point or their purpose in being. And so if those muscles are sliced, or if they're torn or anything like that during the surgery, and they're not repaired, then they're a lot of times having to work a lot harder to try and hold everything into place and to try and stabilize your core. So remember that your abdominal muscles in the front, and you have some deeper abdominal muscles that kind of go in the bottom portion of your abdomen, or in the rear portion of the abdomen. They're basically holding up there to try and keep everything nice and taut. we are bipedal creatures. When we walk around, we like to have everything kind of staying where it should be. We don't like to have organs sloughing around and slushing through our abdominal layers and things like that. So those muscles are there to kind of help hold things together. So if they're stretched out, if they're damaged, if there are problems that occur with surgery, then a lot of times those muscles get spasmed, and as they try and kind of overcompensate for their inability to really hold things in. And when that happens, you can have a lot of tenderness to palpation, you can have tenderness to touching, whatever it may be, a child running into your belly, anything like that. So, that's something to really think about, is to kind of see, think about, okay, well, during the surgery, did I have all of those layers put back together? The second thing is, especially a lot of pregnant ladies will develop what's called the diastasis recti. And what that is a separation in those abdominal muscles. In a non-pregnant person, typically those muscles are kind of like this, and then with the diastasis recti, they kind of go like that. Now, the difference between this and a hernia is a defect or kind of a hole in the fascia itself, and usually it's small enough that you can have things kind of protrude through there. So like you can get intestines kind of go through, you can get, other organs sometimes can go through, things along those lines. And the problem with that becomes, if something goes through and then it can't come back out, it can actually cut off the blood supply to that organ. And in that case, the hernia becomes what we call incarcerated. And when that happens, you can have a decrease in blood supply to that organ or to that structure that can become infected. It can become infarcted or kind of die off from a lack of blood, and can be an actual surgical emergency. But with a diastasis, it is such a large separation of tissue that even if things kind of bulge into it, nothing's going to get trapped. And the defect itself is not necessarily in the fascial layer. It's really more kind of in the muscle, and it's causing that separation, and that's what allows you to kind of, when you stand up, ladies who have a diastasis, or you go from laying down to sitting up, they'll have a large bulge in their belly. Or you may see women walking around that they're like, oh, I always look like I'm 6 months pregnant, or whatever it may be. And a lot of times that is due to that diastasis. So, and that is something to really kind of address after delivery. Obviously, there are surgical ways to fix that. There are physical therapy ways to fix it. There are a bunch of different ways that we can do things we can do to try and help, repair that structure and get it to where, that's not causing any pain. So, when you look at postoperative pain, especially kind of around an incision, so we've, gone from the bottom into where we're saying, well, maybe the structures aren't closed. We've gone, maybe it's a diastasis. And then you have to actually look at the scar itself. Did the tissue underneath the scar actually heal appropriately, or is there a defect in that tissue? Typically, you want that scar to kind of, right after surgery, to have a little bit of tenting. And what that does is that as that tissue heals, it kind of straightens out and pulls that scar flat. If it's healed, like if it's closed just flat without that tenting, a lot of times it will actually tuck in when it heals. And so you see this like indentation. So can it be fixed in a C-section, or is that a completely different surgery? A lot of that depends on the degree of the diastasis itself. And I assume that's probably what you're talking about. Diastasis, if the separation is below the belly button, then yes, we can fix that in a C-section, no problem. And you can, sometimes tunnel up a little bit to the umbilicus, or a little bit above that, to get it fixed, or during that surgery. But especially if you have a diastasis that occurs in the top portion of the abdomen, kind of right above the belly button, as a general rule, we can't really fix that in a C-section itself. You're just not in that portion of the abdomen, hopefully. Obviously, if things going crazy and you have to, for some reason, have an incision that goes from your breastbone all the way down to your pubic symphysis, then sure, you can fix it then. But that is not the norm by any means. So those kind of things are what really are some things we can work on when it comes to helping with postoperative pain following, C-section specifically. So is all the layers, are they intact? Is there a diastasis or a separation of those muscles, or is there an issue itself with the incision to where maybe it's getting a lot more tension on it? The other thing to remember too is with repeat surgeries, a lot of times you're cutting through scar tissue, and then when you're closing things back up, you're putting scar tissue back to scar tissue. And that has not the best blood supply. I mean, it will heal, that's not a problem for the most part, but the blood supply itself a lot of times is not as strong as with a quote unquote virgin belly for that first time surgery there. So just some things to kind of think about. Obviously, things that you can do afterwards to help, right after surgery, belly binders, abdominal support kind of garments, or those are fantastic. They wrap right around your abdomen there, and they kind of hold things in, and especially some of the tighter ones will, potentially assist in those abdominal muscles kind of going back together and lining up appropriately as opposed to being stretched out. I have a lot of women ask about starting to exercise after C-sections or just after pregnancy in general, who have a diastasis. And one of the things that we always want to make sure that you understand is if you're doing crunches as a way to try and get yourself a six-pack abdomen again, just when you have that separation, the crunching actually pulls that muscle apart more, and so it can actually make that diastasis more pronounced. So you want to try and do exercises that are like planks or something that kind of are more isometric, and kind of try and keep those muscles more aligned so they're not being constantly pulled and separated. So let's see here. We had another question about, pull it up here, specifically about hormone replacement therapy and hormone, pellets and kind of things along those lines. Let me see here where it went. Okay, here we go. So testosterone pellets. Are they safe? Are all doctors on the same page about them? I know a lot of gals, mostly in their 30s, are getting them. So testosterone pellets. So the general consensus from the endocrine societies, the North American Menopause Society, International Society for the Study of Women's Sexual Health, ACOG, which is the American College of Obstetricians and Gynecologists, all these specialty societies are that hormone pellets, no matter if they are testosterone, estrogen, pick a hormone, whatever it may be, are not FDA regulated and are not first-line therapies by any means. Now, I will say Testapel, which is a testosterone pellet, does have an FDA indication for men, but not for women. So it's the only one of the pellets that actually has an FDA indication, or FDA recommendation, whatever you want to say. If you go out to some of these kind of either medical spas, you go to some of these places that are doing hormone pellets, really those are being marketed as a large moneymaker for those clinics. And the thing about them is, women who have them, they feel fantastic because you get this huge surge of testosterone, in the testosterone example specifically. I mean, you'll have ladies whose testosterone is higher than a, guy that does weightlifting all day long. And they feel great. Their sex drive is out, off the charts. I had a patient one time that came in and said that her gear shift was starting to look sexy to her after she had the testosterone pellets. But the issue is, testosterone, while it's a necessary hormone, is, you can get supraphysiologic levels to where they become problematic. And especially in, women and men with that, or women more so, what that means is that you can have ladies that have, facial hair that start to develop, deepening of their voice, enlargement of the clitoris, from a kind of non-physical, or visible level, your blood, concentration can go up, your hematocrit, so how thick your blood is, can get a lot thicker, your cholesterol levels can go up, so there can be a lot of problems with it. And the other issue with really high levels of testosterone is we don't have good data to know if you do this for, say, 10 years, what's going to happen. Like, I don't know what your outcome is going to be in that time. So really with any type of hormone replacement therapy, the current recommendation is the lowest dose for the best improvement of symptoms. So if you imagine this pellet goes in, you get this highly super therapeutic amount of hormone, well, that's not really the lowest dose, and so it can cause problems. And the other thing with it too is that it goes up and then it crashes. And when do you think it crashes? Right about the time it's time for another hormone pellet. And you go in and you pay your $200, $300, $400, kind of depending on how much it is, and there you go. You're good for another month or 3 months or however it may be. So really, for pellets specifically, those of us that are doing evidence-based medicine cannot get behind that at this time. There is a place for testosterone supplementation in women, especially in postmenopausal women, but in premenopausal women too. But remember, the goal is to, if you have a hormone deficiency, is to get it back to a physiologic level, not a supra-physiologic level. So that's kind of with that. Let's see here. Collagen peptides. Any studies done about them and possible links to vaginal health, specifically for delivery and post-birth? Not really a whole lot. Honestly, we do know that if you look at kind of peptides and long-chain peptides specifically, going from a hormonal standpoint, like for instance, estrogen is a very specific kind of long-chain peptide. And we know that after delivery, there is a decrease in the brain's kind of ability to maybe synthesize, maybe it's the best word, to kind of use those appropriately. And so there is some data out there that thinks that it's due to this kind of chemical change is one of the precipitating factors towards postpartum depression. Now, obviously, you can think along those lines. You can also think kind of along the lines that women who are breastfeeding, their estrogen levels are really, really low. And so when that happens, if the brain's not getting that estrogen and the progesterone that it needs, like it had when it was pregnant, that can lead to postpartum depression too. So there's a lot of kind of theories floating around there about that. Now, collagen as a just chemical, well, it's not really a chemical, histologic component, collagen is something that helps tissue kind of stay together. And obviously we think about collagen in our skin and in connective tissue. The vagina is no different. And we do know that, as women age, especially as they go past that menopausal transition, the amount of glycoproteins or kind of glycogen levels in the vaginal cells decrease. And what that means is that the cells themselves become smaller and become less likely to accommodate stretch. So they almost become kind of more rigid. It's kind of a better way to think about it. And so with that, any type of trauma to the area, whether it's through sex, whether it's through having a gynecologic exam, whether it's through just trauma to the outside, heaven forbid, if you fell forward on a bike or something like that. If those cells are more rigid and therefore are less pliable, you are much more likely to have an injury to that tissue. And that's why a lot of postmenopausal women, especially if they have the genitourinary syndrome of menopause, or kind of what we used to call vulvovaginal atrophy, will have tearing, ripping, burning with any type of vaginal activity. And that's because the tissue is not stretchy at all. Estrogen, one of the things that it does in vaginal tissue is it kind of allows the number of what are called superficial cells to increase. And what that does is allows that tissue to be stretchier, to be more pliable, and to be more accommodating to any type of, quote unquote, traumatic activity, including sex or whatever you want to say. And sex, if you think about it, it should just be pleasurable trauma. It's kind of a, that's how some people have described it. So the vaginal wall, the vagina itself, that's taking this traumatic insult, quote unquote, and if it can accommodate and if it can stretch, great. You don't really have a lot of tears or problems, but if it doesn't, then you do. And so that's kind of the issue with that. So hopefully that answers that question. And obviously, I don't think I said, but if you have questions, feel free to ask them while this is going on. We've got a couple more comments here, a couple more questions. And then we will kind of go from there. Let's see here. Okay, so we had talked a little bit last time, or we had gotten down to vaginal prolapse, brexanolone, and dermoid cysts. Those were kind of the things that people were asking about last time when we had it end. So vaginal prolapse, remember that all a prolapse is a, one of the pelvic organs, or any type of organ, honestly, for any type of prolapse, that has had a weakening in its support structures, so it is protruding out of its intended space at a greater than normal degree. So in the vagina, we have what's called pelvic organ prolapse, and that can include a cystocele, which is a prolapse of the bladder, a rectocele, which is a prolapse of the rectum, or a enterocele, which is where the small intestine kind of comes down, and then finally a hysterocele or a uterine prolapse, where the uterus kind of hangs out. And these are graded on grades 1 through 4, with a grade 4 basically being that organ is falling out of the vagina itself. You sometimes see, maybe you've heard about women that say, oh, if I stand up, my uterus literally falls out of my vagina. I have to push it back in again and go on my merry way. And that's called a proscendentia. And that does happen. And it's incredible when you see it. These women are walking around and then they'll cough or they'll laugh or they'll jump and then whoop, their uterus falls out. And they say, oh, there it is. And they push it back up in and they kind of go on. So what can we do about that? Well, obviously, first, you have to look at risk factors. So childbirth, well, actually, let me back up. Pregnancy is a risk factor for pelvic organ prolapse. Laboring is a risk factor for pelvic organ prolapse. Vaginal delivery is a risk factor for pelvic organ prolapse. So if you are a mom that you get pregnant and you labor and then you have a C-section, you still have that risk for pelvic organ prolapse because you did labor. Now, we used to say, okay, well, if you have a scheduled C-section prior to the onset of labor, you probably won't have the same degree of prolapse, and maybe there is some truth in that, but the fact of the matter is pregnancy causes a stretching of those pelvic floor muscles anyway. And so when that happens, you're going to have a higher risk for having that prolapse. Other things that can cause prolapse, chronic cough, so women who are smokers that have COPD, if they're coughing all the time, that's increasing the intra-abdominal pressure and possibly pushing those organs out. Connective tissue disorders like Ehlers-Danlos syndrome or some things like that where things just aren't held in as well. Previous surgery to the vagina, so actually women that have a hysterectomy, unless it is a supracervical hysterectomy that preserves the cervix, have a higher rate of pelvic organ prolapse as well. Age, obviously low, estrogen status, there's kind of a list that just kind of keeps going on. But the big kind of question is, what do we do about it? Well, so, the first thing to try and figure out is, are you symptomatic with the prolapse? For, say, a bladder prolapse, are you having leakage of urine when you laugh, cough, sneeze? Do you feel like, you go to the bathroom and then you're like, oh my gosh, I still have to go, and you sit back down again and nothing comes out? Is there something there? For rectal prolapse, or rectocele, where it's kind of prolapsing up through the vagina, which is different from an actual rectal prolapse where it prolapses out of the rectum. Do you feel like you have chronic constipation? Do you sometimes have to actually insert your finger into the vagina to help push stool out? That's called splinting. You have to do that. Uterine prolapse, do you feel like that heaviness? If you're exercising, you feel like something's pulling or tugging deep in your pelvis. So kind of figure out, first of all, are you symptomatic? Secondly, figure out, okay, to what degree of prolapse do I have if I have some? Because that will dictate how we best treat things. For grade 1, especially sometimes grade 2, physical therapy can be a complete game changer for these women. And that's pelvic floor physical therapy and trying to help increase their pelvic floor muscle tone, to try and help their core muscles hold things in. And we've seen women that have come in and say, oh my gosh, I'm having leakage when I laugh, cough, or sneeze. They have physical therapy and now they have no symptoms at all. And honestly, I'm a big proponent of, after vaginal delivery, after C-section, after hysterectomy, pretty much everyone can undergo physical therapy. I think it's fantastic. It's not going to, definitely not going to hurt anything. Once you get into the grade 3 or 4, so physical therapy by itself a lot of times is not going to be sufficient to fully treat the problem, especially a grade 4 prolapse. And so with that, typically we are doing surgery, and that includes a variety of different techniques that, if you want to know more, you can send me a direct message and I'll answer it directly. But that's usually when we do surgical options. Now, for women that don't want surgery or who are not good surgical candidates, there is a device called a pessary. And a pessary kind of looks like, or the most common thing, looks like a little plastic donut, and it fits inside the vagina and it kind of helps hold different organs up properly where they should be. And so, women who, like I said, are not surgical candidates, or they're young and they say, well, I want to still have more kiddos, so I don't want to get this fixed right now, a pessary may be a good option for them. It's something that, you take out, you put in, It's not like you have to go to the doctor's office every day to have it, inserted or whatnot. And there's a bunch of different shapes and sizes of those, depending on what your actual need is with it. But the best thing that you can do to try and stave off prolapse, make sure your core muscles are good and strong, make sure your pelvic floor is good and strong. Don't smoke. Shouldn't smoke anyway. If you don't smoke, you'll start prolapsing. If you're chronic cough, try and increase your protein if you can. But really, it's one of those things that it is most likely going to happen. The question is it going to be symptomatic? And a prolapse without symptom, not really too much of a problem, honestly. Some ladies do complain with some, uterine prolapses that sex becomes more painful or it becomes, a different sensation. And so obviously there are things we can do to address that too from a sexual medicine side of things. But really the big thing is if you have a prolapse, is it symptomatic? And if you're concerned you do, then, visit your handy dandy healthcare provider who knows what they're doing from a gynecologic standpoint and have them assess you and see. Brexanolone, so that was another question that was asked. Brexanolone is a kind of a newer drug. I don't know of anyone around here that's prescribing it. I don't even know if you can prescribe it yet, but it's basically a new medication to help treat postpartum depression. Obviously, I've talked about postpartum depression, a bunch before. It's a huge issue. It's an issue that is very underdiagnosed, undertreated, and having another medication that we can use to help address that is fantastic. Other than kind of what I've found in just doing some research about it, it works on kind of your neurotransmitters, much like a lot of the other antidepressant medications. But it's looking more at dopamine and some things on that side of things as opposed to just serotonin, which is something that, say, like Prozac or Lexapro or something like that. They work on serotonin. So some women that may have serotonin syndrome or may not tolerate a lot of the SSRI class of medications, brexanolone may be a good choice for them. The other thing is it's given in the hospital directly right after delivery, usually from what I've gathered. So that's a big difference too. Other than that, I don't really know a whole lot. Like I said, I know that no one around here is prescribing it yet, but that may be something that we see very, very soon. The last question that I had, or that I was given, was dermoid cysts. Can they reoccur? So, and here's another question that popped up as well. So, dermoid cysts, or otherwise known as teratomas, are cysts of the ovary that are filled with such lovely things like hair, teeth. You can see bone in them. You can see all sorts of great things. And they get very big, and they can cause a lot of issues. But 99% of the time they are completely benign. They're crazy. We've seen ones that have been this big, and you cut it open, and like this whole almost wig of hair is in there. Or you found total sets of teeth. One time found some bone through in with them. So the issue with dermoid cysts for a lot of women is that, like I said, the larger they get, the more pain they cause. And when that happens, one of the other side effects can be that if the cyst specifically is on the corner of the ovary, with walking and moving and things like that, it can cause the ovary to actually wrap around on itself, and that's called an ovarian torsion. And when that happens, the blood supply to the ovary is cut off, and the ovary basically starts to die because it's not getting any type of oxygen. And so those ladies will present to the emergency room with this what's called colicky pain, so kind of on, off type pain. It can be sharp, it can be dull. It can be associated with nausea and vomiting too, because embryologically the ovaries are affiliated with what's called vagus nerve, which is a nerve that comes out of your brain that goes through your stomach. And when it's stimulated, it can cause nausea and vomiting. So those are kind of the hallmark signs of an ovarian torsion. And a lot of the times when we see torsions, teratomas are kind of implicated in that. But if you take them away, can they reoccur was kind of the main question. Obviously, if you were to just do a cystectomy and remove just the cyst, but leave the ovary itself, there is a chance that these cysts can reoccur again on that specific ovary. They are basically, like I said, just kind of tumors of stem cells, kind of the best way to think about them. And so we know that they're, any of our gonads contain gametes, which are kind of, our pre-embryologic sex cells that, come together and, make us who we are. But so if you have a ovary that is ovulating, releasing eggs, you are having that potential of those gametes kind of getting affected with that, and that can potentially turn into a teratoma because those stem cells or those total potential cells are present there. Obviously, having one on one ovary, let's say you had one on your right ovary and you had to have that ovary removed, there's still a chance it can occur on the left ovary too. Just having one by itself does not mean you're never going to get one again. Very, very rare, I will say, but obviously anything's possible with medicine, as I'm sure you're well aware. Is there anything we can do really to prevent them? No. Unfortunately, you just kind of have to watch. And if they start to appear, you can't, some people say, oh, take birth control pills if you have a history of ovarian cysts or things like that. No, that's not really going to prevent this specific type of cyst, from occurring. So let's see here. If you are too active during the first couple weeks of postpartum, can this cause your vagina pelvic floor to not heal properly? Well, so that's, kind of in looking at that, what do you necessarily mean by active? If you mean just, that you're up moving around and you're doing things, probably not. Now, I will kind of, the caveat with that is if, let's say you have a delivery, you deliver like a, large baby vaginally and, heaven forbid you have a fairly significant tear. And the next day, you go home from the hospital and you're out and you're, squatting down and you're picking weeds and you're doing all these things and you're having all, super duper active, then yes, that can definitely, cause some problems. And we do recommend that women after delivery, take some time just to rest. You think about it, your body has gone through 9 months of changes, give or take, to get to this point. Delivery, especially a vaginal delivery, is a crazy amount of trauma to the body, Csection as well. So your body needs that time to rest and to heal. So can being overly active cause some issues? Potentially, yes. Typically, the issues are going to be more likely related to infection or blood loss, but as far as healing the pelvic floor or causing pelvic floor issues, later on the line, if you have problems with those muscles, if you had a tear, and it doesn't heal properly, then that can definitely lead to problems later on. So, this is definitely why we say, hey, give yourself a break, let people wait hand and foot on you, you just birthed another human being, that's a big deal. You don't need to be the one out mowing the lawn or something like that, heaven forbid. I think that's pretty much all of the questions that I've gotten. And I know it's kind of the noontime hour and people are kind of bopping in and bopping out. So obviously, if you have any other questions, I'm always happy to take them kind of on a direct message type, line. And like I've always said before, if you want to kind of actually come in and get seen and evaluated in person, I'm still accepting new GYN patients. There we go. Here we go. Typical house cleaning, walking, lots of walking, attending appointments. Yes, those are fine. That is not going to cause any problems. Now, it depends, I guess, if you have like a 10,000 square foot home and you're cleaning that all by yourself, you probably should, let someone else do it. But if you have a 10,000 square foot home, you probably can have someone else doing it anyway. So anyway, but yeah, if you have other questions, let me know, or, obviously if you would like to come in and get seen as a patient, we are definitely accepting, GYN and sexual medicine patients. So otherwise, I think I'm going to kind of call it a day. It's been about half hour. So I hope you all have a wonderful weekend. If you are, have some fathers in your life, whether that's a husband or a brother, or uncle or dad or whoever, make sure you tell them Happy Father's Day. And I hope you all have a wonderful weekend. And I'll see you later. Bye-bye.